It's a pleasure to have the opportunity to introduce today's speaker. This is a case of reconnecting after many years, and Dr. Frank Franklin is here today through a very busy period of life in the life of a public health epidemiologist. Frank, I first got to know him in the early 90s. We'll just leave it there, as a summer apprentice and later as a research assistant, working with Diego and I in our lab doing lab stuff. I think this program and these types of experiences are so important because they help many people learn what they want to do later in life and develop some skills, we hope, that help them later on. And I will always remember one of the conversations that we had. You know, he was working at the bench. He was very good at the bench doing molecular biology. And, you know, we were talking about what he might want to do in the future. And it was clear to me, but I didn't really want to impose my perspective. But, you know, he kind of was a little bit apologetic, but he says, I really want to go, I think, into public health. I need to work with people. And I really, it was very clear that this was a case of a really bright individual who was meant to interface with the public and not be at the lab bench working with pipettes and test tubes, as good as he was at that as well. But I was so glad that, you know, he was able to use that experience to help solidify his own interests. And we lost touch over the years. Fast forward, I was poking around on LinkedIn and found his name and looked at all of the things that he had done since that time, and was just astonished, not really surprised, because I knew he was very talented, but you know, he went on to get his master's in public health, and he went on to get do a postdoctoral fellow at the Morehouse School of Medicine. He got a JD at Drexel University. He also did a lot of many different types of research and interactions and experiences to really develop a very impressive career in public health epidemiology. He's currently on the board of scientific counselors for the National Center for Injury Prevention and Control of CDC. He's the principal epidemiologist and director for the Multnomah County Health Department, which is the county in Oregon where Portland is, which I had to look up because I'm not that familiar. And when I saw it was Portland, I was like, oh, he's really busy then. That's sort of one of the centers of a lot of the early COVID activity. So, and he's also on the faculty in the epidemiology division of the Oregon Health and Science University in Portland. So, you know, I could spend the rest of the hour talking about the many different things that you've done, Frank, but I want to make sure you have plenty of time to give your presentation and, you know, to have opportunity for questions. We have a very wide audience and we're all looking forward to hearing your talk. So why don't you go ahead and share your screen and make sure everything's working. And we can take it from there. Okay, we can see it. You're muted. Oops.
Try that again.
Okay.
How's that?
That looks good.
Well, first of all, thank you for the invitation, Nancy, and the very warm introduction. And it is truly a pleasure to be here, and so great to reconnect and just reflect on how quickly time flies, right? And you may not have been surprised, but I'm a little surprised. When you get busy in this work, you just kind of put your head down and you keep going, and you look up, and people say, "You've done these things." And you go, "I'm still trying to figure it out." But again, I really appreciate my experience at Monell and the opportunity to work with you. And I'm glad we're back here again. Yeah, I feel like I should have a certification by now when the COVID is over on these technical things. You can only see what I have in front of me to make sure all this works. So I'm glad it's coming out okay. So let's start the conversation. So the title of the conversation here is the traumatic lived experience. And I want to set up a little context for our discussion today. So as in the introduction, as you guys know, I'm a public health epidemiologist. But when you work in public health, you often have to intersect with many different agencies. And not in all, but to a great extent, many of these agencies are health and human service agencies, and arguably so is the public health department. So, and I want to connect this sort of idea of the traumatic lived experience, and also sort of give the audience understanding of how this pertains to my work, how it's important to my work, but I think it's important to many areas of work. So when we're attempting to tackle issues of the human condition, particularly in the health and human services space, the concept of the personal narrative or the lived experience is, I believe it's vital in confronting these issues. And in the absence of that lived experience or the integration of the lived experience when tackling those issues, I would argue that these efforts are often, particularly in the long term, are often fruitless. So although the lived experience of a human service professional, and in many instances, the workforce in the human service sector, you have many individuals who come from a similar narrative of the individuals that they're serving. So that lived experience, although important and it's necessary, yet as an exclusive reference point, I would also argue that that personal narrative or that lived experience is insufficient. And when I was putting this talk together some time ago, I think about the lived experience, I think about being at church when I was younger with my mom. And, I'm not sure if many of you share this similar experience, but when you're young, your mom is sort of, your parents are dragging you to church and you go because you're supposed to go. And often in some instances, and depending on your denomination and the type of church you go to, sometimes the church experience or the sermons can get very spirited and people can become very interactive. And I remember as a little kid asking, okay, in the back of my mind, thinking, what's going on? Why is this happening? And I remember asking my mom, why is this person having this particular response to the sermon? Because I was a little scared being younger. I didn't understand it. And I remember she would always say, you have to keep living. And you haven't lived long enough to understand it. And I just recently lost my mother over the holidays. So whenever I talk about her, it sort of it makes her many words of wisdom. I could do a whole hour about just sort of a book of her words of wisdom and advice. But now that I've gotten older and had some experiences and surely have many more to go, as she would always remind me. But I have a better understanding of what the lived experience is and how important it is to understand the facts that you see in front of you, or as scientists, we're trained to observe conditions or fact patterns. And so having that understanding of the lived experience helps with that. So let's start with this idea of disparities, equity, and trauma. I think these words have become very popular in the public sphere as of late. And I think for me, they've always been a part of the public sphere by the nature of the work that I do. But now they're sort of transcending beyond just public health and moving into many, many different spheres of the public. And I think it can be useful to either unpack or complicate these terms or concepts in an effort to come to a simplified yet meaningful interpretation of what trauma means for you and what it means for the work that you do, what disparities mean, and what equity or inequities mean. Often they're used interchangeably or they become conflated. Notwithstanding the overlap between these three concepts or ideas, there are some boundaries that make them inextricably connected, but yet distinct. And so whenever I talk to students or sometimes my staff, or even my colleagues in public health, when we talk about these terms, we often get, or the discourse sort of moves down this path of what I call textbook recitation, or a mimicking of something you may have heard in popular discourse. But it lacks an individualized comprehension or understanding or interpretation. So when I put this presentation together, I believe I had a bunch of public health students and some folks in the legal profession, as well as public health practitioners. So I decided to sort of structure this in what we call in the law, when we're looking at legal issues, we often immediately conceptualize this framework of what we call IRAC, which is issues, rules, analysis, and conclusion. Similar to or analogous to the SOAP notes that physicians may use. And so the issue is generally the question that we're trying to interrogate or the question that we're attempting to understand or wrestle with. The rule is basically the law that sort of guides this particular area of facts. And the rule in the sort of most narrow sense is the statute. But I also apply this in my day-to-day work and with my staff in terms of how to communicate issues to me in a sort of memo-like format with this framework, although many of them don't realize it's sort of a legal way of communicating, but it sort of helps structure the conversation. So in the most strictest sense, the rule is the statute. But in a more sort of practical sense, the rule can be the usual and customary practice. It can be a policy. It doesn't necessarily have to be a statute, but it's an attempt to sort of connect how has this been handled historically, right? Hence, is there precedent or is there not? The analysis is then taking that rule and applying it to the observed facts to sort of provide an interpretive order, if you will, and understanding the fact pattern or your observations. So let's start with disparities defined. And this is sort of how we sort of approach questions, in the law anyway. Sort of, what's the rule? How are we defining the rule? What's the definition of the statute? And going back to my observation or my perspective on how the words disparities are always not fully, I think, comprehended. And so in one of our staff meetings with my team, one of the charges of my unit or my division is to sort of set up guidelines, standards for how we analyze data, and how do we do that with an equity lens. And the first thing that came up in this sort of workshop meeting we have in our epi rounds is, in this particular round, what's the definition of disparity? So at that time, so the team was about, I don't know, maybe about 15 epidemiologists from varying degrees of experience and training. And so we go around the room and we're all sort of defining disparities. And I went last intentionally, and because I just wanted to see sort of, here's a word we use every day. every day. And it's like the word leadership. We use it every day, but if you ask a million different people, you can potentially get a million different answers, right? So then it begs the question, is there a definition, or what does it really mean? And if that definition is it stationary? So I got a lot of different answers. I got a lot of long answers. I got a lot of textbook responses or canned responses. None of them were actually necessarily, and it wasn't about a right or a wrong, but it was just an exercise to sort of to see if our charge is sort of to get the department on the same page. Can we get these 15 people on the same page, right? And so at the end, for me, after listening to everyone, I came up with the definition, and it was this distilled definition of disparities is defined as a non-random differential outcomes and health status due to structural positioning, period, right? And these are sort of terms of art in here. I'm sure some of you recognize them, not all of them. So when we think of non-random, we think of obviously something that is free from bias or, in other words, equitable, differential, statistically or unlikely due to chance alone. And then there's this idea of structural positioning. And when you think about structural positioning, it's sort of looking at how people are positioned in society based upon income, occupation, education, social class, gender, race, ethnicity. Those are the more common ones. I'm sure you can always add some additional ones, maybe neighborhood, nationality. But this structural positioning shapes the benefit burden distribution conferred by a person's position in one or more of these particular social constructs. I like to think of as a benefit burden distribution. Some people think of in terms of opportunities threat distribution, but I think benefit burden sort of has a nice ring to it, so I'll stick with that. So we have this definition here. So when we think about this definition of disparities, that's sort of the rule, the one that's going to be the first rule in which we sort of engage the next set of slides to talk about different facts. And I want you guys to kind of keep this in mind in terms of how disparities has been defined here. So let's look at the first fact pattern. Here are 3 facts. Trauma tends to be more frequent in racial, ethnic, minority, and low SES groups. The lifetime prevalence of PTSD was highest among Blacks compared to other racial ethnic groups. Death and despair. You guys may be familiar with that or recall that language or terminology that has been popularized in the newspapers recently. And it's a sort of a term that's been an outgrowth of the opioid epidemic. So when we think of deaths or despair, I also think of the earlier crack and HIV/AIDS epidemic, neglected in recent narratives about despair in the US, but yet they also produced a decline in life expectancy in the United States, similarly situated with those outcomes associated with opioid-related deaths or opioid-related misuse or hazardous use of opioid substances. Fact pattern 2. Several US states are pursuing overdose prevention sites. I think Philadelphia has been involved in this for the last couple of years. Yet the DOJ, the Department of Justice, has warned that overdose prevention sites would violate the so-called crack house statute, which makes it a felony to maintain any place for using controlled substances. In May 2017, the US Supreme Court ruled on racially discriminatory intent of voter suppression laws, refusing to revive a North Carolina election law that the Fourth Circuit Court of Appeals had found to target African Americans with almost surgical precision. That's in May 2017. And then here we are in 2021, facing a similar issue with Georgia. Between 1996 and 2016, the number of segregated schools, in this case, segregated defined as where there's less than 40% of students who are white, has doubled. The percentage of children of color attending such schools rose from 59 to 66%. And for Black students, the percentage rose even faster from 59 to 71%. Fact pattern 3, Black men with no criminal records are less likely to receive job interviews than are white men with criminal records. Incarceration levels are so heavily concentrated among some groups that incarceration has become a normal stage in the life course, which is, when I read that, I think I knew it, or somehow it resonated with me because as an African-American male, I have a lot of friends who are or have been justice involved. But to sort of contextualize it in this health language of that it's a part of the life course, that's another way of saying it's almost part and parcel of your narrative, just like adolescence or puberty or midlife crisis, right? Within low income or within low poverty areas, Black men who grow up in census tracts with greater racial bias measured by tests of implicit bias or explicit racial animus, they earn less and are more likely to be incarcerated. The last fact pattern. I know it feels like a lot, right? That's law school for you. So in 2014, Blacks at all age groups of the Black-white health gap were more likely than whites to have lower rates of education, to be unemployed, to live below the poverty level, and less likely to live in a household with the head of the household owning the home. In 2015, Blacks had 40% higher death rates than whites for all-cause mortality in all age groups less than 65 years of age. In 2017, the Federal Reserve Bank found that Black consumers are 73% more likely to lack a credit score due to credit redlining. And here, credit redlining, although similar to the redlining that we may be familiar with in real estate practice, this is an extension of that, although not the same. So essentially, credit redlining refers to where consumers who live in a particular area, their credit worthiness is determined by the neighborhood they live in, this, in spite of the fact that they actually may have good credit. So, unless reflecting back on the disparities of our rule here, again, the fact pattern or the analysis of the fact patterns, and whether you pick one of these or all of these, is not necessarily designed to provide an absolute answer. Instead, again, the rules are utilized to establish an interpretive boundary of the outcome described by the facts, right? And this is important. I think it's deeply important to epidemiologists as I work with students who on doctoral committees and master's committees or presentations, and I too probably have been guilty of this, and it's probably part of our training that's evolving and getting better. But nonetheless, we're trained to understand the statistical and the epidemiological research strategies, interpret these sort of probabilistic analyses, provide the data, provide the results, and then there's usually what I call a drop the mic. They give a high level statistical framework, which I can appreciate, and they give me all the bells and whistles, and then they drop the mic, but there is no sort of it gives this sort of an attempt at giving what I call an absolute answer for things, or maybe the hard numbers, if you will, but it lacks an interpretive boundary or an explanatory boundary to, if you will, prognosticate the next steps. Right? As an epidemiologist, your patient is the population. So it's no different if you went in to see your physician and he or she took your temperature and ran some tests, gave you the numbers, and then walked out of the office. Right? So where do we go from here? Right? It's information, but it has to be instructive. So the numbers in isolation, I often say, you do a disservice because you reduce it to information, because it's not connected to sort of an interpretive boundary, an explanatory framework. And then the explanatory boundaries are defined by theoretical or academic information, but also defined by experiential knowledge and understanding of that person's experience in the context in which they live on a daily basis. So again, taking the rules to understand or interpret the facts that we observe. And this resonates with any type of, not just the law, but any science, right? That's what we're trained to do. So we have this definition of disparities. And so here's my attempt at being interactive here, because when this presentation was designed pre-COVID, so there was an opportunity to get feedback from people in the audience with clickers and things like that. So we'll do the next best thing. So issues. Issues in the law. When we hear the word issue, we hear that translates into what is the question, right? Similar to what is the research question. So we have the fact patterns. What's the issues that arise from these fact patterns? Do these fact patterns in isolation or in whole, do they qualify as disparities? And do they qualify as inequities? So if anyone wants to put any respond with any of the chat function, please feel free to do so. But going back to the definition, is it one or the other, or is it both? Next question, the next set of issues. Can disparities and parity exist at the same time? Can equity and inequity exist at the same time? And for me, this was an important question, or a question for some serious consideration. Often when we're trying to address issues of public health and we talk about parity or disparities and equity and inequities, people often ask of myself and my colleagues, how do we eliminate the disparities, right? Or how do we get to parity? Or what does parity look like? What does equity look like? And I would argue that we have a great deal of experience in designing, implementing, and executing an equitable response to health disparities. Responses that produce parity for those who are afflicted. However, it depends on who the group and how the narrative is defined. And often the narrative is defined by the group themselves. So when you think about substance use and the opioid epidemic, and I use this because it's most recent, I think it's fresh in everyone's mind, but I can come up with several other ones. When the narrative of the opioid epidemic or drug use has often been, and particularly prior to the opioid epidemic, has been sort of, it's a function of some personal internal flaws of the person. So these addictive afflictions have come about because of the person, some moral failing of the person. And the alternative, when we when we look at the narrative of opioid use and opioid-related deaths or hospitalizations, the narrative is often characterized as, in spite of this person, they have become afflicted with an addiction. In spite of being a good mother, in spite of being a good son, in spite of being a hard worker, in spite of being a loving brother, so it happened to them. Whereas when it's characterized, or when opioid or addiction was stigmatized as more of a Black-brown issue, it becomes a function of, because of who you are, or because of what you are not, we sort of have these conditions. And I think there are a lot of great examples of addressing substance use disorder in a way that provides equity and helps to eliminate disparities, but not necessarily across all groups. The way we have responded to the opioid crisis in terms of using this concept, this practice of harm reduction. Harm reduction fully incorporates, acknowledges, and utilizes the narrative of the person in order to respond to the disorder or to respond to the public health issue. It sort of meets the person where they are. So we know what an equitable response looks like. We understand, we have many examples where we have practiced incorporating the narrative, but we have to value all narratives equitably. Another example is the COVID response in terms of testing, equivalent exposures, yet differential needs, right? Meeting the narrative. Also, substance use disorders, or the substance use disorder response among pregnant women, that has been managed differently depending on which population of pregnant women you're considering. That has been managed differently not only in hospital practices, has been managed differently in statutes, statutory law, as well as case law or bench law. So again, similarly situated narratives, yet different responses. So I would argue that we do know how to create parity, or we do know how to create responses that incorporate the narratives of the individual. The question is not whether, it's less about whether or not do we know how to do that. It's sort of what's the value, what's the compass that's going to drive our values of these different narratives. The next rule, trauma. And we hear a lot about trauma. I mean, the value of being trauma-informed, having a trauma-informed response, having a trauma-informed organization. And then if you ask people, again, sort of how you define trauma, you get a lot of different varied answers. Or what does a response look like premised on your understanding of trauma, right? So trauma is defined here as exposure to intense and overwhelming experiences of serious loss. And here I underline certain words because they're like buzzwords or terms of art for epi folks. You have the exposure to threat or harm. So it's exposure to intense and overwhelming experiences of serious loss, threat or harm to a person's physical and or emotional well-being. So it doesn't have to always be physical harm. It doesn't have to be actual harm. It can occur in any time in a person's life, maybe a single event or maybe repeated over many years. And it can overwhelm the person's coping resources and may cause serious harm in the long run. The severity of trauma is often gauged by the dimensions of time, such as duration or frequency, to assess exposure and risk. Time and frequency are often thought of as independent or discrete events of exposure, yet over the life course, arguably, frequency is the bridge or connection to a state of continuity or continuous exposure. So some more ideas or questions for thought. Is trauma a consequence of disparities? And then are disparities a form of assault? And if so, then are disparities a form of violence? Third rule of the World Health Organization: violence is defined as the intentional use of physical force or power, threatened or actual, against oneself, another person, or against a group or a community, that either results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. And I think this definition, a little wordy, but I've seen more word than this. But I think it's great in terms of laying out, and again, these are buzzwords for me as someone trained in the law, because we're talking about the intentionality here. It's intentional use of force or power, and it can be threatened or it can be actual. And it can be for an individual or a group. And so when we think about the intentional use of force and power in different communities, how we respond to different communities, and as it relates to sort of human issues, whether it's public health, whether it's justice, whether it's education, whether it's employment, how we respond to these groups, but how we respond to community and neighborhoods, that either results or produces this high likelihood of impact. Again, impact can be physical, but often it's psychological, and it does contribute to a maldevelopment or deprivation or privation, if you will. So then thinking back on sort of this idea, the definition of disparities, the definition of trauma, in and of itself, the lived experience in a racialized context, or a context sort of demarcated by racism, is that a traumatic lived experience? When you think about trauma, trauma is a consequence of assaults shaped by disparities and inequitable conditions. These assaults are physical assaults, but also there's civil assaults on one sort of existence, franchisement, and engagement, and the public sphere. And most often, the daily lives of individuals, particularly the Black and Brown communities, are impacted by what I call sort of civil assaults. However, given the popular media, I don't know, I could say these days, or I could say this week or yesterday, we see the physical assault that are experienced by Black and Brown individuals. But whether physical or civil, assaults are nonetheless. And when we think about assault as defined in the law, again, it's considered sort of the imminent threat of actual or perceived harm, right? So whether you define violence in the legal sense or violence by the World Health Organization, it's the two pretty much support or imbalance, or they're in balance with one another. So the disparities and the inequitable conditions. So the disparities produce inequitable conditions, and therefore you sort of have this traumatic experience. And the disparities and inequitable conditions are a form of violence, which I would say that have been mechanized through the structuration of race and the production of racism, as well as the other structural components of gender, education, and income. But here the focus is looking at sort of the racialized experience, or the experience of racism, and how that has become an enterprise for producing disparities and inequity, and maintaining a high level of persistent and prevalent trauma within communities, affecting people's health, and well-being. So when you think about the traumatic lived experience, I often call it the violative lived experience. And violative is sort of an awkward word, but I like the word because it speaks to an experience that where you're constantly navigating a series of violations against you physically or civilly. Right? So the disparities produce these inequities that present themselves as routine assaults across one's life course, which result in trauma or ill health or ill-being, but driven by structural positioning or the term, when you hear the term structural violence, I often use that term and people say, what is structural violence? And structural violence is sort of the consequences or how people are sort of treated given where they are in the structural context, whether it's based on gender, race, income. But the unique thing about sort of race, unlike the other areas, one thing is, and speaking particularly of education, income, some of those areas, race is sort of immutable, right? You can improve your education, you can improve your income, you can improve your social class, but race is immutable. It's there. Also, unlike the other areas, when you think about sort of how the permutations exist, race can be connected to all those other areas, unlike in the reverse. You can't always connect these other areas to race. So as an African American or as a person of color, you have the race and gender, the race and occupation, the race and income, the race and you name it, right? So when we talk about the COVID, for example, we should think of this COVID as a syndemic experience for African American people, and often their experience in general is syndemic, meaning you sort of have two types of epidemics, if you will, two or more epidemics interacting with one another within that one system. So whether it's COVID and race, whether it's education and race, whether it's occupation and race, whether it's access to employment, access to healthcare services, there's always sort of this syndemic narrative of the African American, a syndemic narrative of the Black and Brown experience. And so for me as an epidemiologist, and I get questions from time to time, people will ask me, I just had a reporter ask me the other day, and you know, I take things for granted because when you're in the space, you're just in the space and you assume everyone else sort of has a similar share of meaning. And so the reporter asked me, she says, well, are you a disparities researcher? Do you do disparities research? And for the first time, I had never thought about it. And I thought it was a weird question. But, I realize how, again, we conflate terms, but we don't sort of think about them more critically. We don't come up with different questions. We don't come up with different questions. We can't come up with different answers, and therefore we can't come up with a different response. But what I said to her, anyone in public health practice who's doing any type of substantive work, inherently you're engaged in disparities, right? So, it's just which disparity. Are you in racial ethnic disparities? Are you gender disparities? So I said, I guess in that sense, I am a disparities practitioner or a disparities researcher. But disparities in and of themselves it doesn't stand alone as a concept. It's embedded in the work. So as an epidemiologist, people ask me, sort of, how did you get to this space? But I had to get to this space to sort of better understand what I was seeing in the numbers, right? To ask better questions and to sort of hopefully provoke a different way of thinking to produce a different way of getting to different responses and more broad responses. and to sort of generate new evidence, because we have enough evidence of what we're currently doing in a lot of areas isn't working. And it's not about sort of solving the problem. It's about sort of consistently critically engaging the issue in order to address the problems that arise for the time in which you're in. It doesn't necessarily go away. Yeah. So that was my last slide. So now I'm open for questions, comments, or discussions.
Really, really informative, important concepts. Thank you. We do have some questions that were posted in the chat. I also invite people to either add questions to the chat or raise their hand or just open their mic. I have some questions too, but I'll start with the ones in the chat. Is anyone addressing the notion of meeting people where they are from sort of a industrial engineering or supply chain perspective? Maureen, this was your question, so if you wanted to clarify or open your mic, that's fine.
My mic's open. Hi, Frank. It's nice to meet you.
Hey,
yeah,
nice to meet you.
I'm in a house full of industrial engineers. And it occurs to me that there's often fabulous programs out there and access is an issue. And unless you reach the person exactly when they need the information, it's hard to access a lot of help that might be out there. And I've got a family sitting around the dinner table designing how can we get things to people. And so I'm wondering if there's a research area where those two intersect.
I'm going to take a leap of faith and say yes, but yet I'm not 100% certain. I mean, when I hear it, I think of more of a supply chain type of dynamic. How do we get vaccines? How do we get supplies to people?
Yeah.
Yes, it's probably an underdeveloped space. And like many areas, there's an opportunity for public health to sit at the industrial engineer table and vice versa. We often, in our profession, sometimes get a little insulated about the work that we do and don't realize that there's so many connections, except when there's an event like a COVID. So yeah, I would say probably yes, but not in this particular area. Probably in those large CBOs or those non-governmental agencies, international NGOs who are trying to get supplies to places. Because I've often thought too, like, wow, I can go online, buy a car and have it delivered to my house, but I can't get a vaccine. I can't get
well, and it's not just, yeah, and it's not just if you treat information as the product.
Yes.
Then that's where I think it sort of could get interesting.
Yeah, it can. A lot of that also is dependent upon a lot of the improvements that need to occur in the sort of analytic ecosystem of public health agencies around data analytics and information as assets. So we're catching up a little bit.
So I think my question, which relates a little bit, I think, is, you know, in your diagram, and I really like that, the violence, disparities, inequity, assault, trauma. Where do you, I mean, obviously, where are the critical touch points that you can start to intervene to shift? And this is like the big $60 million question, right?
You know, Nancy, so it's like that chicken or the egg question, or the question that I was, and we continually get faced with is sometimes is sort of, is it substance use or is it mental health, right? And at some point, I would say or suggest that it probably doesn't matter, because what happens is each step becomes interdependent on the other, and it needs to be disrupted somewhere. And it
Right.
doesn't really matter because of that interdependency, but also it doesn't necessarily matter as much because no matter where you intervene, it can never be retroactive, right? Right, so it doesn't, so it can only be have perspective benefit and hopefully create that sort of positive disruption, if you will.
Mhm.
I think
Interesting.
sometimes that can become a distraction. I mean, it's an important question, but you know, it's like, where's the best? At this point, why don't we just start somewhere, anywhere, right? Right.
Right, right. That
Yeah.
makes
So I would say anywhere, and I say that also in terms of an encouragement of a more of a broader set of disciplines willing to engage the space, right? You don't necessarily have to come in and have this evidence of why and where you should engage, but more or less reverse the conversation to why you should not be engaged.
So another question in the chat comment has to do with the notion of violence and a couple of related points, whether it has to be physical. Are there sort of events or experiences that maybe don't rise to the level of trauma or violence if it only happened once, but if it happens over and over and over again, you get a sum that's greater than, you know, the individual event. Because it seems to me that those two scenarios, the scenario of a single violent event versus maybe something that it's sort of easy to ignore once, but maybe not 50 times. There might be different ways of thinking about those scenarios and different ways to approach looking to change or address them.
That's a big one. I'm going to try to grab how it landed on me. If I miss something, please circle back. Certainly, and clearly, maybe not clearly, that's why we have the conversation. Violence does not have to be physical. It can be, and again, that's sort of what our normal go-to, but violence can be psychological, right? And although the severity of a violent event or traumatic event can be assessed, or its magnitude can be shaped by the frequency and duration, but also the nature of the event itself, right? Depending on the nature of the event, a one-time event can extend a certain level of trauma or persistent trauma across a life course or across a person's lifespan. So it depends on the nature of the event. And again, that goes back to sort of the fact pattern of each event, right? You have to kind of look at them individually as well as sort of the totality of events, or the totality of traumatic experiences that a person may experience, or a violence or an assault that a person may experience.
So I guess my last question would be maybe to just give us maybe an example of one of the initiatives or an initiative or a program that you've seen in your experience, either recently or historically, that was particularly effective. Program or a like.
Mm-hmm. That's a tough one, right? Maybe I'm a little too critical. I think some of the more effective programs, and usually these programs are a little bit more labor intensive up front, sometimes not as popular in terms of the fiscal or the resources required, but some of the, and I'm going to describe them sort of categories of programs, not necessarily a particular acronym, a particular club for a particular program. The one category of programs are those programs or those initiatives that really are designed to be disruptive in a positive way and attempt to change a person's or community's neighborhood context, right? And by that I mean you have to bring these sort of services and these opportunities to neighborhoods and sort of help reshape the neighborhood, meaning it's not simply enough to move a person to a high income neighborhood instead of a low income neighborhood. You really have to build that neighborhood up and change the living conditions, or the opportunity to change the living conditions in terms of the type of housing, the type of education, the type of work, the type of services to support that, to begin to build this intergenerational change. So for example, there's a theory on the distribution of disease called the ecosocial theory. And the short end of that theory, the premise of that theory is that a person embodies his or her historical contemporary context, which then in turn shapes the future, i.e. intergenerational well-being. So those neighborhoods that are those projects, there's been some in Atlanta, there's been some in New York, some other places where they actually go and try to sort of rebuild the neighborhood, not displace the people, rebuild the neighborhood with the same people. Right? In a more individualized level, some of the initiatives that I've found to be beneficial or useful are those programs that sort of center in a theme of mentoring. And I use the term theme because all mentoring programs are not good, but you really have to develop a substantive mentoring program. And I think it's some of the programs I've been involved with in terms of working with young African-American boys and sort of helping shape their trajectory from adolescence or preschool moving forward, having that mentoring, a comprehensive, long-term, intensive mentoring to then propel, hopefully bend the curve, if you will, or bend the trajectory of that young man's narrative in a direction that will be fruitful for him, his family, as well as the community in which he decides to reside in. And similarly for females, I just happen to have more experience with the young man program. So, and those things are sort of changing the neighborhood context and changing out, as well as sort of the mentoring theme or areas that I found to be useful at producing well-being, whether that's avoiding violence, whether that's in producing better health behaviors. So it's really about the production of well-being and all what well-being means.
Yeah. Well, that I see our time is up. Hard to believe, but I think mentoring is a really a good ending point, because that is something that we both as professionals and individuals in our communities and in our associations can grab onto. And I think your points about the type of mentoring being really so important is really critical. And I think, we may have some follow-up conversations with you about that, because we're advancing some new mentoring programs, both at Monell and through the Association for Chemosensory Sciences that many of us are involved with. So I want to thank you, and this was really very thought-provoking and really, really important information. I really appreciate your time today.
Thank you. I've enjoyed it thoroughly. Thanks.
Thanks. Have a good rest of your evening.
You too. Thanks, everyone. Thanks. Bye-bye.